medical and postgraduate degrees from the University of Stellenbosch. She established and headed the pediatric ophthalmology service at Tygerberg Children's Hospital for 15 years. Then she transferred to the Red Cross Children's Hospital and the University of Cape Town. She's a co-founder of the South African Society of Pediatric Ophthalmology and Strabismus and has been its president, a member of the scientific committee of WSPOS, an examiner for the South African College of Ophthalmology, has lots of fellows, and she has special interests in pediatric glaucoma. This is her lovely family, and you can see even in South Africa there's snow. What can I tell you about Alicia Sarah? Alicia is a superb individual. She was part of the first local organizing committee for the first WSPOS in Barcelona 2009. Here she is with her lovely husband, their nephews and nieces. Here she is examining someone, and she organized my youngest son's 18th birthday in Barcelona. That's the kind of friend she is. She works at the Sant Joan de Déu Children's Hospital. Her private practice is at the Institute Castanera. She participates in lots of clinical trials and research, and she's a part of the lead network for ROP and telemedicine in Catalonia and in Europe. And she's a member of the European Pediatric Ophthalmology Society. In fact, she's a member of the board. Alicia, welcome, welcome, welcome. Roberto Caputo, again, what can I say? A great colleague, a great friend. He's got his degree in medicine and surgery at the University of Florence, residency at the University of Florence, observer fellow at Moorfields and Great Ormond Street, got his master's in pediatric ophthalmology at the University of Florence. He's a member of the Childhood Glaucoma Research Network. He is an amazing individual. He is with his family, mountaineering, biking, amazing. Roberto, thank you so much for joining us today. So on that note, Menti questions 1, 2, 3, 4 are up. I am now going to hand it over to Nicola. If I can just... Nicola, all yours.
I'll start with introducing Ken. Ken is truly a global citizen in the true sense of the word. He has Punjabi heritage, but was born in Nairobi. He has lived and received his degrees in England. His fellowship was done at Sick Kids in Toronto, and he has worked as a consultant and clinical lead in Great Ormond Street in London. And for the past 8.5 years, he has been division chief of Pediatric Ophthalmology and Strabismus and Adult Motility at UPMC Children's Hospital and the Vice Chair of UPMC Eye Center in Pennsylvania, USA. So truly a global citizen. He is absolutely passionate about teaching, and I think some years ago he realized that even though he was invited to hundreds of meetings all over the world, knowledge was still not reaching every colleague in every corner of the earth. Thus, in 2009, he co-founded the World Society of Pediatric Ophthalmology and Strabismus, and I think he did this to ensure that pediatric ophthalmology knowledge and expertise is made accessible to every pediatric ophthalmologist in the world, no matter how remote and how poor their country may be. As you can see from these pictures, Nicola,
I don't think you're sharing. You're not sharing the slides.
Okay. And show.
Perfect.
Can you see that?
We are not seeing anything at the moment. But you know,
Ken, when you were presenting, I was also not seeing your slides.
Okay. All right. Let's carry on then. We'll fix that. And Todd will fix that for us. Go ahead. Keep going.
Okay. So Ken has a very loving family, and he certainly knows how to have fun. A special word of thank you for your inspiration to so many colleagues and for your contribution to pediatric ophthalmology globally. Next, I'd like to introduce, but now we can't have Sushmita's pictures. Can we just sort this out, please?
It's always the wonderful thing about live webinars is that you practice and you practice, and then on the actual time, you can't see it. So the web.
Can you see that now? Do you see my screen now?
No, we don't. And Nicola, you're right. It looks like my screen wasn't showing either. I am just going to, Nicola, let me just try and share this. Can someone give me the okay as to whether you can see that now? Can you see my slides?
Yes, they're visible now.
Okay, they're visible?
Yes.
All right, okay. I tell you what we're going to do now, right now. Nicola, while we fix your end of the problem, I'm just going to very quickly, can everybody see my slides? Can someone give me a yes? Okay, yes. So this is the Worldwide Connect. This is what we were trying to show you guys earlier. This is the registration fees that I talked about, but you couldn't see anything. And this is the rotating world. Looks like we are now an okay. This is the QR code. The code is 857776. And I want to show these beautiful pictures. Nicola, you are fantastic, but your kids are better than you. Your husband is not so good, but you look fantastic, and look at you skiing. And these are the pictures. Alicia, look at you, how beautiful you are and how kind. Look at that, with all those nephews and nieces. And Roberto, I hate to say that you definitely let the family down. You've got a beautiful family, and there's Roberto with his bike. So I think we are now fixed in terms of that, and I'm going to stop sharing. And you should have the screen.
So do you see my screen now?
We don't yet, but while we are waiting for you to come on live, I'm just going to tell everyone, we have at this moment Sri Lanka, India, Bangladesh, Pakistan, Indonesia, Nepal, Myanmar, Russia, Lebanon, Sweden, Chile, Colombia, Brazil, Hong Kong, Mexico, South Africa, Nigeria, Argentina, Italy, Australia, USA, Singapore. It goes on. It goes on. Nicola, I would carry on with the introduction, and we are hoping that our technical staff will make sure that the screen can be shared. So.
Okay, well, I'm just delighted. I'm absolutely delighted it's not my technical problem. In that case, I can go quite comfortably. I have some pictures I have a crazy picture of Ken decorated in color as he celebrates one of his family celebrations. So I was finishing off with Ken. Thank you for your inspiration to so many colleagues and for your contribution to pediatric ophthalmology globally.
Thank you.
I'd like to next introduce Prof. Sushmita Kaushik. She's the Professor of Ophthalmology at the Advanced Eye Center in Chandigarh in northern India. She specializes in glaucoma and has a special interest in childhood glaucoma. She is the co-founder secretary of the Indian Paediatric Glaucoma Society, vice president of the Chandigarh Ophthalmological Society, is a former secretary of the Glaucoma Society of India, and she's in charge of the teaching program at her teaching hospital. She has 120 publications in reputed international and national journals, and she's contributed to 35 chapters in various glaucoma textbooks. She's a reviewer for several reputable journals, and she's the recipient of numerous awards and honors. She regularly receives Best Presentation Award at meetings and congresses. And I've had the privilege of hearing her speak at the UK Paediatric Glaucoma Society and the World Congress of Paediatric Ophthalmology and Strabismus in India, Hyderabad. Sushmita, we are enormously grateful to have you share your knowledge and teach on this platform today. Thank you very much. Next, and do you know, are my slides sharing yet?
I'm getting a message, Nicola. Could you go onto your screen and stop sharing and then reshare? The technical hitch is that when we first started sharing, that link didn't go out.
Okay.
So if you stop sharing. So while Nicola is fixing that, I think it is important that we introduce everybody appropriately. So are you sharing again?
I can start again. Are you happy for me to share?
Yep.
Are you seeing that now?
No, we're not. Not
Doctor
yet.
Ketan, can you help him?
Okay, so while we're waiting, we got precious time, so I'm going to kick off with a small discussion. I want people to think about this. Here's a scenario. I got called to see a 3-day baby. She had corneal diameters of 13.5 millimeters. The corneas are completely cloudy. What I can see is that there's a posterior embryotoxon, and when I look at the mother doesn't know it, but she has Axenfeld-Rieger syndrome. But the mother didn't know it. I do a UBM in the ICU. Okay, we were sharing. Well done, Nicola. But I'm going to finish the scenario. I do a UBM. There is no iris. The anterior segment is 1.1 millimeters. That's the chamber depth. Think about that, guys, because when we come to the discussion, I'm going to ask each of you how you would handle that. Nicola, take it away. You're sharing. It all looks good.
Okay, so thank you, Sushmita. Apologies, but I'm glad to know that that was not my error. Here are the pictures I had of Ken, of his loving family, and we know that Ken certainly knows how to have good fun. Thank you again for everything you've done for pediatric ophthalmology globally. Sushmita, we look forward to your lecture. Thank you so much. Next, I'd like to introduce Professor Sir Peng Khaw. He is a professor of glaucoma and ocular healing and consultant ophthalmic surgeon at Moorfields Eye Hospital in London. He has a special interest in anti-scarring therapies and surgical therapies for glaucoma and optic nerve regeneration. He has developed surgical techniques which have markedly improved the safety and outcome of antimetabolite-assisted trabeculotomy in many parts of the world. He is constantly involved in the development of new surgical instruments, anti-scarring drugs, and their delivery systems. He is the director of the Biomedical Research Center at Moorfields Eye Hospital and UCL Institute of Ophthalmology in the United Kingdom. Incidentally, this is the highest ranked ophthalmology center in the world in the most recent World University subject rankings. His publications include over 500 papers, chapters, and books, and he has helped to raise over $150 million US dollars for research and research facilities. The Richard Desmond Children's Eye Hospital in London is only one of Prof. Khaw's many successful endeavors, and I've had the privilege of seeing this hospital that is dedicated to pediatric ophthalmology. Professor Peng is most certainly one of the most influential ophthalmologists worldwide. He holds a Platinum Clinical Excellence Award, which is the highest possible award from the British NHS. In 2013, he was knighted in the Queen's Birthday Honours, one of 2 ophthalmologists in the last century for his services to ophthalmology. Professor Peng, we are enormously grateful and honoured that you are willing to share your time and share your knowledge. Everyone in this audience is eager to hear about your research and glean any of your tips on how to optimize drainage blebs in children. Thank you so much.
If you could stop sharing, that would be great. And
Yes.
I think we're going to put Menti questions 5, 6, and 7 up. And Peng, I introduce you and welcome you to start sharing your talk once Nicola's stopped sharing.
Which I'm having difficulty with. There we go.
There we go.
Sorry about that.
That all looks great. We can see your presentation. Thank you.
Okay, let me just, it's gone to the wrong bit of the show. Let me just go back to slide 1. Yeah, okay, good. Hallelujah. Can you see it? Can you see my slide?
Yes, it looks great.
Great. Okay. Very quickly today, I'm going to talk about optimizing blebs and drainage surgery. And particularly relevant is, although Vision 2020 is this year, glaucoma still doesn't feature very much on the priority. And one of the reasons is we don't have a one-off treatment for glaucoma. There's been a further shadow cast upon ophthalmology, which is COVID-19. And the other day, it took me 3.5 hours to do a surgery because of the new aerosol work. So this is going to pose great challenges and put greater emphasis on us being able to do surgery very quickly and efficiently and safely on our patients. Since you've seen the Spitfire, I thought I'd use Winston Churchill. A pessimist sees difficulty in every opportunity, and an optimist sees as opportunity. So we may have to look at opportunities to take this very difficult scenario forward. These simple graphs of big studies show that if you get the pressure down to a good level in the low teens, you have minimal progression. And of course, that must be even more important in children. And this now, I'll just refer back to adults. We've set a very ambitious challenge for World Glaucoma because of this issue of glaucoma. And we've set the 10-10-10 challenge, which is a pressure of 10, lasting for 10 years, but done in 10 minutes. Now, the requirements of doing surgery like that is it's got to have lots of S's. But most of them have got to be simple, speedy, scar-free, stable, and sustainable, but it's got to be safe. And today, just the brief messages I'm going to talk about are some of the things that make drainage surgery safer. I'm going to go straight to some of the changes that we've made in surgery over the last few decades. Really, very simple things. A large anti-scarring treatment area, posteriorly directed fluid flow, good flow of the aqueous that potentially is adjustable. And these simple innovations and these simple changes have made a big difference to our outcome. Now, this is a slightly big bleb because the slide is slightly stretched. But what it shows here is a bleb flap that basically is got limited side cuts. It's designed to control the flow of aqueous backwards because a posterior flow of the aqueous gives you a diffuse non-cystic bleb. And of course, in children, that's incredibly important because they have a lifetime of risk of endophthalmitis if you've got the highly cystic bleb. It's very important to understand that when you're operating on a very big eye, it's got low ocular rigidity, and this is some of the excellent work done by our bioengineer, Jan Bremel, looking at how you control the flow of a flap. And it's very important to try and structure the flap so that you get control of flow. Never leave an eye soft at the end of surgery, particularly if you've used antimetabolites, but also potential of how you can increase the flow by adjustment or using adjustable sutures. Now, we use adjustable sutures, although because we control the flow at the time of surgery, we don't often have to adjust them. But here you see a little video of adjusting some of the sutures through the conjunctiva so that you can loosen the flow but not get a sudden gush of fluid that you can very much in children with glaucoma. Now, anti-metabolites or anti-scarring strategies have been really the mainstay of making filtration surgery work. I mean, obviously, angle surgery is the initial mainstay of lots of surgery, but if that fails, external drainage surgery is really the thing. And these various things that we have to prevent scarring have made a huge difference to our lives. But they result potentially in very undesirable blebs. And to cut a long story short, you get a cystic bleb because you get a ring of scar tissue, which we call the ring of steel, and you get flow of aqueous, which is anterior rather than posterior. And therefore, your surgery has to minimize these if you're going to keep these children going for the rest of their lives. So the principle of a diffuse cystic blebs, whatever anti-scarring technique you're using, is to make the surface area big. So this was counterintuitive when we first started it, but making as large a drainage area as you can gives you a diffuse posterior non-cystic bleb. And you can get profound improvements. This is the more for one eye and the other eye of the same patient, and you can see the fundamental difference in bleb appearance you can get, and minimizing some of those complications you see on the right there. Oops. If you look at the results of changing the appearance of a bleb, you can see it's absolutely extraordinary. If you see bleb-related problems, and of course in children it's cumulative year after year, 20% if you do a limbus-based small exposure, and 0.5% if you do a fornix-based bleb, and that's been reproduced in other studies around the world. And also, using these principles, you can see this results from doing trabeculotomy with the safer surgery system in children. You can get pretty good results, even in the long term. And again, in adults, there's been a dramatic reduction in complications of surgery since we've been using these better techniques. And this is a national survey showing the difference between before and after of all the sort of complications we fear, such as hypotony, visual acuity, and other problems. Now, these principles don't just apply to trabeculectomy. They apply to tubes, and even traditional drainage tubes with a plate, but they also apply to, we've been working with different new generation drainage shunts. And again, this teaching slide, this next slide, which I borrowed from their teaching slide, because Paul Palmberg took our technique of MMC, and it was this broad technique of treatment of MMC that made it possible to develop the InFocus, because all the other early trials had a very poor results. But the one with the technique of broad MMC application was the one that enabled them to come through to be a successful treatment. We're looking at other simple ways that you could use around the world for anti-scarring, and we've revisited beta radiation. Some of you will have heard that, and some of you will be very scared of this because you're thinking of pterygium. But this is a completely different way of applying it, and a very, very relatively low dose. And the recent trial in Africa, in African patients, showed that your chance of having an IOP less than 16 millimeters of therapy in Africa was 5 times as great if you use beta compared to mitomycin. So we're developing some new probes which can deliver this in 30 seconds so that worldwide this is a possibility. Of course, inflammation, I haven't got time to talk about that, but very important to reduce inflammation post-operatively using steroids and whatever adjuncts you have, including the use of local anesthetic at the time of surgery, which considerably reduces inflammation and scarring. So in conclusion, external drainage surgery, including tubes, is still the mainstay, and we'll talk about this when we go to Ken's case, when angle surgery fails. The principle here is that very simple principles of techniques to manage flow and bleb, which you can apply without buying a expensive instrument or anything, can fundamentally alter your outcomes. The long-term effectiveness and safety is enhanced, and these improved techniques in the future will also be possible based on the same principles. I know many of you really around the world make such a big difference to all the patients you look after. And I'll finish with a quote of Winston Churchill, which is, we make a living by what we get, but we make a life by what we give. And I'm sure all of you do that. So thank you very much. And I will stop sharing now. Okay.
That was wonderful. Thank you so much, Peng. I think, Alicia, if we can get you to talk next, and then we'll have a discussion. While we're waiting for Alicia, I've just found out that we have Kazakhstan, we have Spain, we have Indonesia, I've already said that, we have Namibia, we have Switzerland, we have Germany. So welcome everybody, and this is truly a global event. Thank you so much everyone for joining us.
Sorry. Okay, thank you. First of all, I would like to thank Ken and Nicola to invite me to participate in this webinar. And when they proposed me this topic, when does goniotomy not work for pediatric glaucoma? I said, yes, I'll do it. But then I was thinking, which is the question they want me to talk about? In which cases it doesn't work? Or when it doesn't work, then what? So finally, I decided to talk a little bit of both, but very quickly. And first of all, I'd like to review the normal angle development. It starts at the 5 months of gestational age by means of a posterior migration of the iris and ciliary body attachment from the Schwalbe's line in the 5th month and backwards to achieve the scleral spur in the 9th month, and then to a location behind that postnatally, and probably a lot of months after birth. Goniogenesis is produced because an arrest of in the development of this angle recess, and then you can see these findings. You can see an anterior insertion of the iris, the inner layers of the meshwork of the trabecular meshwork are not fenestrated, and also attraction on the iris roof by thickened trabecular beams that compact the trabecular meshwork, obstructing the outflow. Also, in the more severe forms of developmental arrest, in the more early forms, filtration never occurs, and then the Schlemm canal is not permeable, at least in some sectors of the angle. So goniotomy is the surgical technique that consists on the section of the trabecular meshwork from the inside of the anterior chamber, and that the intention is to open the angle to cut the inner layers of the trabecular meshwork and relax the tractions, and then allowing the aqueous of the humor outflow. The goniogenesis is present in all the forms of primary congenital glaucoma, in some forms of systemic pathology, like the early forms of glaucoma in Stuch-Weber and NET1, and in some syndromes, and also in some acquired ocular pathology like Axenfeld-Rieger, aneurysmia, Peters, and so. Also in some acquired pathology like chronic inflammation and steroids, they produce changes in the trabecular meshwork that increase the resistance to the outflow, and that and then behave as an goniogenesis. And at least in glaucoma following cataract surgery, if the surgery is performed during the first months of life, then this early removal of the lens could arrest the angle recess formation because of lack of accommodation or whatever reason, and EVM showed that there is a high insertion of the iris. So we are inducing goniogenesis. So in which cases does goniotomy don't work? First of all, of course, when there is not a goniogenesis to treat, but also when the goniogenesis is very severe. And we show the results of our goniotomy practice in the last meeting of the UK PGS in London in January, and we show the retrospective results of 255 eyes, in which we perform goniotomy as an initial procedure. And as you can see here, our global success rate is 72%, which is at the lower range of that published in the literature, which ranges from 70 to 90%, but the results differ widely depending on the type of glaucoma. As you can see here, in neonatal glaucoma, we have a success rate of 22%, but in infantile and late onset, the success rate is over 90%, and these differences are statistically significant. Very few publications do analyze this difference, and in Walton series, neonatal glaucoma have a success rate of 15%, and in Schaffer's one, 30%, which is more or less about the same. These poor results are due because the glaucoma is present before birth. That means that the developmental arrest was produced very early, and then the Schlemm is not permeable, as I commented earlier. And for this reason, some publications describe also poor results for trabeculotomy in this neonatal form of glaucoma. In the contrary, in infantile glaucoma and late onset, the results are very good because this pre-interval for the beginning of the glaucoma means that the SLEM is functional. So that's why the goniotomy it's successful. And in other forms of glaucoma with goniogenesis, in the early form of Sturge-Weber, our success rate is 70%, in rigor 60%, in aniridia 75%. In uveitis and pediatric aphakic glaucoma, we have performed a very few cases with poor results, but in the literature there are published very good results from other authors, so we have to keep in mind. And the second part of the question is, when goniotomy fails, then what? And this is the algorithm that was published in the Consensus of Glaucoma of the World Glaucoma Association in 2013, I think. And Professor Peng Khaw performs a survey monkey with including hundreds of specialists in the world, and in front of the question what to do when angle surgery fails, there was not unanimity. 44% of the surgeons prefer trabeculectomy, 30% tubes, and 26% other techniques. So it's not easy to answer this question. A very quick review: trabeculectomy has a very variable success rate and with a high variability among the series because of different reasons. But almost everyone has agreed that the worst prognosis is obtained in children younger than 1 year, in which the success rate is 18 to 30 or 36%, different papers. And comparing with children over 1 year, in which the success rate is much higher, and also in aphakic glaucoma in children, in which the comparison with tubes are it's very clear, except in this paper, but the follow-up was only 14 months. So almost everyone agrees that in these cases the tube is better than the trabeculectomy. So the indication of trabeculectomy will be primary congenital glaucoma, in which goniotomy fails or angle surgery fails and the children is older than 1 year, juvenile glaucoma, and some secondary open angle glaucomas. And drainage device, the results are better in most reports and at the long-term basis, but we have more complications, and the indications will be as a fair choice in most cases of aphakic glaucoma and uveitis, and in late onset of Sturge-Weber, and after goniotomy fails in children with neonatal glaucoma younger than 1 year and Sturge-Weber, and when everything has failed. So that's it. Thank you very much.
That's wonderful. Thank you so much. So let's start the discussion. Peng, are you with us still? I think right. If everybody could
just unmute.
So let's go back to this case that I described. 3-day-old, 13.5 diameters. Looks like the child's got axon-flat rigor. What would you do, Peng?
I agree very much with Alicia, really. I mean, if they're born at onset with very large eyes and with opaque corneas, they're in a terrible prognosis group, probably the worst group. And in my experience, and I think Alicia's results show that, really only drainage tubes with plates work. Now, the problem that you have in your patient is that you've described is that the AC is very shallow. And putting a tube into a shallow anterior chamber, well, first of all, you've got to find out why it's shallow. But let's say it's just shallow and it is not particular adhesion. Then you've got to work out why. We had a recent child who was blind in one eye from posterior segment disease, and he had exactly the same FEBR in the right eye. So we couldn't do any laser or anything because he'd had PVR set off in the other eye by this thing. So what we ended up doing for putting a tube in him, because he was losing vision in his only eye daily, he was getting whiteouts, was we put a micro tube into the anterior chamber and then used that as the portal to go into a tube. And that's worked very well for several years now. So I would still go for a tube. I would try and do anything. If you're putting tubes into the anterior chamber, then a very good tip in an opaque eye is you can do virtually everything if you put air into the eye and you transilluminate. Because you can see, I've done lensectomies, I've put tubes in and not hit lenses and things. If you put air into the AC and you transilluminate, you can see most things in the anterior segment, particularly of endoillumination, even in relatively opaque corneas. So basically, I would try and do a tube and do whatever techniques necessary to get a tube in. With my
yeah, thank you. Alicia?
No, it's very hard case. I think I will try to lower the pressure with medical treatment to have a more or less clear cornea. And if it's possible to do angle surgery, I would try. Although the prognosis is very poor, and probably I will put a tube also if the anterior chamber is a little wide enough.
Nicola?
I have a question for the panel. Would anyone temporize with cyclodiode instead of going straight to tube? Just as a temporary, especially if the child was even younger. Just because we know that the failure rate is so high with the tube. Would you, knowing that it's not going to last long, but just temporize with cyclodiode?
You mean until the AC deepens, and you
yes.
get some control,
just to buy some time.
Yep.
What is the panel's opinion on that?
Let's ask Roberto. Roberto and Sushmita, let's bring you into the conversation.
Yeah, the first answer should be to send the patient to Professor Khaw. The problem is when Professor Khaw is on holidays, then I will follow Alicia. I will try with medication, with a cetazolaminate to lower the pressure, and then I will put a tube.
Okay. Sushmita?
I think our preferred is a combined trab with trab. We would combine the trabeculotomy and trabeculectomy. That's our preferred for all newborn. I would be very hesitant in putting in a tube if, as you said, the AC is just 1.5 millimeters. My concern would be the cornea. So I would try with a combined first and then take it from there.
Okay. Nicola, I'll tell you what happened in this case. The child is now 6 years old. I actually did temporize with cyclodiode laser. The reason why I did that is that in every child that's had a tube that has been sent to me for a second opinion under the age of a month, the cornea has melted. I have now a series of 4 children sent to me from different places. I had one when I was in London. I've had 3 now sent to me to the United States. The cornea rubs on the inner side of the tube rubs on the inner side of the cornea, and they get a localized melt. So I have stopped putting tubes in these very young infants, and I try to temporize. I'm interested in if you did a trabeculectomy, Peng, and I know that you said you wouldn't, but and Sushmita said she would. If there's no iris, what do you do for those first few days? Do you put viscoelastic in the eye to keep the eye, keep the lens away from the cornea?
No, I mean, I think using an infusion, and you can put an infusion safely, even in a phakic eye with a relatively opaque, because as you know, we put in the infusion not this way, but obliquely, so that I can do it even in a flat AC in acute angle closure. You can do a trabeculectomy in this, and again, it depends on this issue of flow. I won't leave an eye until the AC is persistently formed, and you do that, of course, in combination with having an infusion and appropriate suturing. So again, I wouldn't probably do a trab in this case, but in an anoritic eye, if you are doing trabs, and I've done quite a few in those, I would make sure that my flap was adequately closed. And in most trabbies, using the infusion and gauging the flow, I don't use viscoelastic. So I essentially don't use viscoelastic either for tubes or things, because I try and control the pressure now with the infusion and with appropriate, ligation in tube case or in a trabeculectomy with the right number of sutures.
Okay, so let's just broaden this a little bit then. So does anybody on the panel, if they're doing a trabeculectomy, use releasable sutures in children? Anybody do that?
I'm probably the only one, but I rarely have to release them because I try to set the pressure. Yeah, I'm probably the only one.
So I use releasable sutures as well. Do you, Nicola, do you use releasable sutures?
I used to when I worked with adults, but it's not realistic in a setting where you don't have enough theatre time. Because those patients would need to go. If you're going to make it releasable, you've got to know that you're going to have enough time to get back to theatre to do the releasable. So it's not feasible in a setting where we've got too much pressure on theatre time.
So just so that people know what you're talking about, because I've had this problem speaking globally, a theatre, everybody, is an operating room. It's not that Nicola is in a cinema watching a movie. I had that problem when I moved to America, and I said, I'm going up to the theatre, and they said, you've got a case in the OR. Roberto, do you do trabeculectomies?
Well, not so much, because it's not so easy to manage the bleb in children, because every time you have to bring in the theatre and to do anesthesia. So if I can, I prefer not have a bleb. But anyway, when I cannot find a Schlemm and I have to convert in a trabeculectomy, then I use a releasable suture.
Alicia, what about you? Do you use trabeculectomies?
I used in children, in all children, yes, I do. In pediatric congenital glaucoma that discompensates in older children, I do trabeculectomy, and in younger children I prefer tubes. And in the middle, between 1 and 4 to 5 years, it's very difficult to decide. It depends on if it's easy to have control of the patient or not. Depends on where he's living, on the behavior of the child. I don't know, there are a lot of... I'm scared to have a children 2-3 years old with a bleb and who is rubbing the eyes continuously. That is very dangerous. So...
Okay, we'll come back to that. I think that's an important point, but we'll come back to that. We have some questions flying in. So somebody says, could we do a limited anterior vitrectomy in an attempt to deepen the AC? I guess he's talking about this particular case, or she is. I mean, I have never done that. Has anybody done a vitrectomy to deepen the AC? I have never done that.
I have done vitrectomies in microphthalmic eyes, like, who have very shallow ACs. I've had to do vitrectomies before we can actually even change the lens, actually. But I usually do that with a vitrectomy colleague, and then I'll put a tube in. But like I say, we've got a little bit more option with shallow ACs now with the microtubes, because they're much, much smaller than conventional tubes, which is 600 microns. So, but I mean, I understand most people won't have access to that. So it depends why the AC is deep. I think the comment about the AC won't get deeper. In a child that presents at birth with a shallow AC, they're going to have a shallow AC. So you're going to have to deal with that as a long-term concept unless you take the lens and deepen the AC manually.
Yeah. So into this case, so I did cyclodiode laser. I cleared the corneas. I bought 6 months time. AC's deepened to about 2.5 millimeters, and I put tubes in. So there are parts of the world where people may not have the expertise. And do you think using cyclodiode laser is an issue? I didn't do 360 degrees. I did 180 degrees, lower half. And I did that with my experience and my pediatric cornea hat on. So I'd be interested in putting our global hat on. There are going to be people who have access to cyclodiode laser who may not have the expertise in a case like this to put a tube in. What do people think about that? Anyone? Peng?
Roberto? Sorry. I think there are downsides of using a laser, and the ones I've noticed most of all is in the early days when I did laser on one eye to temporize while I was waiting and doing a trab or something else on the other eye. I noticed that the outcome of the second eye with the laser was much worse. Now, having said that, in patients like this one who present at birth, their outcome's awful. So basically, the laser is if that's all you've got and you're not used to putting in tubes and stuff like that, that's not a bad thing. But there are downsides of using the laser. The other thing I would tell people to be careful of if they are going to use a tube is that don't laser the area where you're going to be putting the tube.
Right.
Because in the past I've had the sclera disintegrate with a great big hole in the eye where the laser was, and then you have to compensate by all sorts of techniques. So just be careful if you're using the laser. Don't do it where you're going to do a penetrating operation.
Okay, we've got a couple of minutes of discussion before we move on. We are going to run 10 minutes over, so if people have got planned to do something at the dead on at the half hour, change it. Your hair appointment can wait 10 minutes. Let me ask Alicia. Alicia, what lens do you use when you do a goniotomy?
Swan-Jacobs.
Swan-Jacobs. Let's just go around the. If you do a goniotomy, what lens do you use? So you use a Swan-Jacobs. Alicia, Nicola?
Swan-Jacobs as well.
Sushmita? Wow. Peng Khaw?
Ocular make a modified Barkan lens for me, which has a huge surface view, so I use that lens.
Thank you, I use the Barkan Hoskins. I'm not sure if it's the modified one, but I get it from Ocular as well, so maybe it is. Roberto?
Swan-Jacobs.
Okay. All right. So we will come back to the discussion. We've got lots of questions. Nicola, do you want to introduce our next speaker?
Our next speaker is Roberto, and we're looking forward to hearing about 360-degree trabeculotomy. Thank you, Roberto.
Thank you, Nicola, and thank you, Ken, for the invitation. I'm a little bit scared to talk about after Professor Khaw and Alicia, but anyway, it's my turn. So, this is my disclosure. So I would like to follow this scheme on this presentation: why, when, and how to do a 360 trabeculotomy. Why? Because it's probably the more effective than conventional angle surgery. And there's something wrong. Okay, great. So if you see at the most recent literature, there is a paper in the journal Pre-Proof on the American Journal from the group of Moorfield, John Brooks, Maria, and Fribourg and Mexico. And you see that the success rate is definitely better in the 360 trabeculotomy than conventional angle surgery. And same results have been shown by the group of Allen Beck of Atlanta, and you see similar success rate, and definitely better in the 360 trabeculotomy with a similar rate of complication. That's why in the last few years I shift to 360 trabeculotomy. When? When probably because I follow a little bit Professor Khaw, when I have a clear cornea, my first choice is still goniotomy. But when I have a cloudy cornea, then I have to approach ab externo, so 360 trabeculotomy could be a good choice. So which are the steps to doing this surgery? Phoenix-based conjunctival flap, scleral flap, Schlemm's canal location. I try to fill the Schlemm before with the CXO Prolene probing. Then I put the microcatheter and we pull the microcatheter and suturing flap a conjunctiva. I want to show you a short video. I prepared the scleral flap. Then we try to identify the Schlemm canal. We see in this case it was quite easy to find it. Then I try to fill the Schlemm before with the 6O Prolene before opening the very expensive microcatheter. Then I put a little bit of viscoelastic and we try to cannulate the Schlemm canal with the microcatheter. Then as where I switch off the light and I follow the flashing light along the limbus. Then if you can reach 360, you grasp and pull the microcatheter. I try not to open 360, but a little bit less, because I don't want to have iris within the cut. Then you close I try to close even the cut over the Schlemm, and then I perform a Seidel. It's finished. So which are the technical difficulties that we can face? The first one we have seen in the slides of Alicia. Sometimes the Schlemm is not well formed, so it's not easy, like in this case, to find the sclerocornea junction, the blue-white junction, where the Schlemm is located. Because in a case like this one, it's very difficult to locate the Schlemm. So that's why if you are trying to perform a 360 trabeculotomy, it could be dangerous. The second difficulty is if you get an obstacle, an obstruction, then what can you do? You can try to rotate the probe in order to pass through the obstacle. Otherwise, you can remove and re-enter in the opposite direction. Anyway, if you cannot pass the obstacle, but you pass more than 180, 200 degrees, you can cut in the base of the obstacle, and then you can pull the microcatheter, and you obtain a larger opening of the trabecular meshwork. So another problem, we have seen this in the slide of Alicia, when you have an anterior resection of the iris, so you have to imagine that you have a cloudy cornea, so it's very difficult to see the angle of the anterior chamber. And when you engage with the probe, you risk to engage the iris and to have an damage of the iris root. So, for example, in this case, I was quite confident to be in the Schlemm. I have tried with the Prolink, you see on both sides. Yes, but what happened? There was a conventional trabeculotomy. On the right-hand side, the trabeculotomy was okay, was fine. But when I went on the left side, you see the inferior arms of the trabeculotomy was engaging the iris. Why I'm showing you this? Because if you are doing a 360 trabeculotomy and you pull the microcatheter, or worse, if you are using a Prolink suture, then you can make a very large damage of the iris roots. So you have to pay attention. So which are the pros of this kind of surgery? It is probably more effective than conventional angle surgery. It requires less number of examination under anesthesia, and you know the neurological developmental problems of the children, with the same rate of complication. Which are the cons? Probably a longer learning curve, a longer surgical time, and the cost of each probe. Thank you.
Fantastic. So it gives me great pleasure now to introduce Sushmita. While Sushmita is sharing her slides, I would like to tell you with the first question that we asked was how many of you have done a 360-degree trabeculotomy, and only 11% of the audience have done a 360-degree trabeculotomy. So I think that's going to be very informative. And then I'll give some other answers as we go along. Sushmita, take it away.
Good evening from Chandigarh, and thank you, Dr. Ken and Dr. Nicola, for having me. Great honor to be amongst everybody. So the photographs have been taken with parental consent. We know since the last couple of years now that glaucoma drainage device is useful, and it helps us change lives of many, many children. And there's enough published literature. I've just put up the ones for the newest kid on the block, the ADI, the oral aqueous drainage implant, which is a low-cost alternative to the Barvit. So compared to the adults, and I found this one paper which compared it head-to-head, though the efficacy was similar, what the problem was with complications. There was tube retraction or migration, which was far more than in adults. They had more encapsulated blebs and endophthalmitis, but interestingly, the corneal decompensation was more in adults than children. So what are the problems that we have in children? One is the problem of tube placement, because remember, it's a very, very stretched limbus, and the anatomy is quite distorted in that area where we are putting in the tube. Then fashioning a long track is tricky because the scleras are stretched and thin, and of course migration and retraction due to eye growth is a problem. So this on the bottom, you can see when we put in a second tube, really, the first, which behaved perfectly well, except for not controlling pressures, also decided to migrate towards the pupil, and we had to go ab interno and trim both of them. The quadrant placement needs planning in children. So this is post-trauma. This was an open globe injury. This boy went on to develop a retinal detachment fixed with silicone oil. So we like putting in the tubes inferiorly because we've seen that silicone oil tends to go up if they emulsify and cause more fibrosis. The only two little tips while doing an inferior tube is, one is you always fill these vitrectomized eyes with viscoelastic, and the other thing we do is do a little bit of shelving internally but leave the external absolutely snug. And the other thing is, if we go underneath the tube, it's easier to cut it bevel up, and then the bevel is quite well. So these are the two little caveats in case we are putting an inferior tube, and then it really goes in quite easily. When we have an optical penetrating keratoplasty, we need to be really careful, and these are the children who do land up with secondary glaucomas. One thing that we take care of is that we keep the tube underneath the host cornea and not let it go on to the graft. So if we take care of that, that helps. So this little baby with neonatal glaucoma eventually landed up with an OPK, but then she was gifted right back to us with intractable glaucoma, but she's about 3 years old now and doing well. Sometimes there's no choice. You need to put it in the sulcus simply because there is no anterior chamber and the iris is stuck against the cornea. So if it's pseudophakic, as in this child with secondary angle closure, it really doesn't matter. All you need to do is have a little longer tube, and what you can do is cut it just so you can see it within the pupillary area. You'll see it in a bit. So you can see it just within the pupillary area, but it doesn't obscure the optical or visual axis. The problem is sometimes when you have, like this child with axonfil riga, had the iris stuck to the cornea and there was no anterior chamber. So we were a little heroic in this kid. We thought, let's try and put it in the sulcus because the iris is so far away from the lens, and we tried to put it in a phakic lens. So as you can see, we had to cut the tube again. We put it in, it hit upon the equator of the lens, so we cut it again and we put it in, and we thought we'd done a very good job and inserted it just beyond the equator. So you'll just see that in the next couple of seconds. So as the tube goes in, so we had a little bit of a problem because the second bevel wasn't as good as the first one, and then it stopped right at the edge of the equator, and however the tube found its way. It wasn't touching the lens. It's still holding on a year later. There is a space between the tube and the lens, but then because the iris is stuck to the cornea, it has stayed. So this was an interesting thing that we thought. This is another kid, yet again, with axonfil. You could see a completely closed iris. What we did here was make a little peephole. So rather than try and do that, because she's phakic, there's a clear lens, rather than try the heroic things we did, what we did was used a vitrector and made a little peephole into the peripheral iris so that we could put the tube into the sulcus, as it were, and yet be able to see it next morning. So here you see we are just cutting it a little bit. I think we went a little overboard. And here when we are doing it, we use very, very low cut rate, almost 50 to 75, and low vacuum as well, so that it's controlled. And here you can see the tube. And next day, we were happier with this tube because it's just beyond the equator, not touching the lens, yet you can see it. So we call it a peephole, and it's helped us in these children now. Another tip, in case you choose the pars plana, so this child had microspherophakia with glaucoma, so she had undergone a PPL and PPB and was referred to us from the retina side. We thought it was easy. We put in a tube in the pars plana just under the iris, but to our horror, there was so much of vitreous. So don't get carried away that a PPB has been done, because a pars plana vitrectomy does not necessarily take care of the skirt of vitreous, and we've learned that. So of course this child, you can see the sutures are still in, so very early we went in, we completed the skirt vitrectomy around the tube, and you'll see those vitreous strands that we are pulling away or we're cutting out from the tube until the tube was really clear of these strands of vitreous, and then it worked very well. So next morning the tubes are absolutely clear of vitreous. So that's just one tip. Even if it's a vitrectomized eye, make sure before putting in the tube in the sulcus or in the pars plana to do a skirt vitrectomy before doing so. Now, should we avoid or should we not avoid a patch graft? I'd like to refer you to this publication from Dr. George Puthran from Aravind. This is coming out in the AJO. They actually did a randomized controlled trial in both children and adults with and without a patch. And the surprising thing was they found erosions in the group with a patch, but didn't find erosions in the group in which they made this large, long scleral tunnel. And this paper also has a companion video, so it shows how the tunnel is made. This 4 millimeter tunnel that they made did not have anything. So there's the small clip I'm showing you, which has helped. I thank Dr. Jamie Brandt. I've borrowed this from one of the videos, borrowed the technique from one of the videos and tried it in one of our children. And this micro crescent is available, and this works very well. So he calls it a windshield wiper, kind of making a sleeve, and it's easier than doing the long needle track, and the sleeve, the tube really goes easily in. The only thing is you have to make a small scleral, partial thickness scleral window there, because otherwise the tube would be exposed at the limbus. So that's easy to do, a tiny thing and into it. And post-operatively they do very well. It's absolutely flat, it's smooth, there's no allograft there, so they do well. So the take-home points really, surgical maggots are, the tube entry should be as far posterior to the limbus as possible because it's distorted. Cover the tube, whether you use a patch or a scleral tunnel, doesn't matter. It should be parallel to the iris, and secure the plate to prevent movement of the tube. But we also need to tell the parents to take care that they don't press their eyes or rub it too much. These two girls, one of these is the one who I showed you, the vitrectomy one. They both had microspherophakia, intractable glaucoma, and both of them have 4 tubes between them. Thank you.
I have to tell you, I've been absolutely mesmerized by all the talks, starting with Peng, Alithia, Roberto, Sushmita. These are, I mean, for anybody listening to this webinar right now, this is absolute gold dust. And I can tell you, the questions are pouring in. But let's go through to some of the questions. Nicola, you interrupt anytime you like. Any questions?
Okay. One of the questions is to the panel is, for those parts of the world where they do not have mitomycin available, what would you recommend if you don't have mitomycin for pediatric case that you should be using it for? Sushmita, what would you suggest?
Well, Dr. Mandal has never used mitomycin in his primary trab so he would probably say I don't need it. The alternative he does is makes a single suture trab, but then Dr. Mandal's hands and the rest of the world's hands are completely different. So he says that with single suture trab you don't need MMC, but I really wouldn't know what to do because I do use MMC in all my trabs.
Just to clarify for people listening, so Anil Mandal is a great proponent of the combined trabeculectomy with trabeculotomy. I mean, I do that as well. And I think that, as you say, he does a single suture. His videos are on YouTube if you want to see them. He's a great surgeon. I'm just going to tell you what I do. I started doing releasable sutures when I was in China, when they didn't have mitomycin in some of the oldest hospitals that I went to. the reason why I do the releasable suture in infants is not to maintain the anterior chamber. It is, in fact, at about 5 to 6 days after the initial surgery, or up to 7 days, is to release that single suture. I use one releasable suture to increase the drainage. Because in infants, the fibroblast response is so terrific, and I mean that in the true sense of the word, that by giving that second rush of aqueous coming out, by releasing that suture, I've had much better control. So I still do that when I use mitomycin, but my releasable suture is done more to allow increased flow 7 days down the road. And in fact, you can release it in the clinic. You know, I leave that suture buried in the cornea, but there's a little bit that's flat, and I use a Q-tip, and then I just pull it out. Normally, the children are fasted for 4 hours. They come in, the mother feeds them, and you can almost do anything when they're postprandial. So that's what I do. Now, for those infants, I use viscoelastic because the elasticity of the cornea, of the sclera, is such that the releasable suture doesn't work unless you put some viscoelastic in the eye. So that's what I do. Peng, what would you recommend if there's no mitomycin?
Well, the world shortage of mitomycin recently has really focused our thoughts on this a lot. Now, we do have mito back now. But in the interim, obviously, not many people have beta radiation, but as I've shown you from some of the recent results, it's very effective. So we've been using that. And for those of you who don't have beta, you can get 5-fluorouracil. And if you look at the trials that were done on adults, there's intraoperative 5-FU on a sponge is less effective than MMC, but it's still effective. And don't forget the use of other enhancing agents that you can use. So don't forget to leave Marcaine underneath the bleb, because we've shown that that has a significant effect on the fibroblasts, and you've all got Marcaine. And for those of you who have bevacizumab, Avastin, which is relatively inexpensive, aliquoted from the big vial, use that as well, because that also works on a different pathway. So all of these are strategies that you can use, and some of these may be available to you around the world.
Thank you.
Anybody else got anything to add before we move on to the questions? Okay, so if you're going to use mitomycin, what concentration do you use? Who wants to take that on? Alithia?
0.2.
0.2 milligrams per milliliter? And how long do you apply it for?
2 minutes.
Oops, sorry, my internet's going in and out. Sorry if I've interrupted anybody.
No, go ahead.
I use mitomycin. I use actually 0.5 now on most people. When we wrote the Morflow system, it was 0.2 and then 0.4 and 0.5, different depending on the things. I mean, obviously, if the conj is very thin, or you've got very thin tissues, then you may have to modulate that. But otherwise, I would use 0.5 and make sure that all my sutures or my ligations are secure so I don't get hypotomy. Because ultimately, it's the wound healing that determines what the final pressure is and your success. So I now use 0.5 for pretty well everybody, actually.
Nicola, Roberto, Sushmita?
So what we do is we change the concentration depending on how heavily pigmented the eye is. So in a black patient, we would use 0.5 milligrams per ml, and in a young Caucasian blue eye, perhaps 0.2 milligram. So it varies depending, and also in a uveitis patient, maybe higher concentration. So it varies depending on the patient, the age, the pigmentation, how many previous surgeries, all that plays a role. But it's somewhere between 0.2 and 0.5.
Does anybody disagree with
0.4.
Okay. So, Sushmita?
0.2, but we don't vary concentration, we would vary time rather than that.
Me too.
0.2 for 2 minutes for most, but in case I require it, I would maybe keep it for a longer time, 2.5 or 3 minutes, if it's a previous surgery, post-vitrectomy, post-PK. But for de novo cases, 0.2 into 2 minutes, yeah.
And so what is the exposure time for everybody else? For the 0.5 milligrams per mil, how long do you expose that on the multiplegics and the wider area?
Well, I use 3 minutes for everything because we did an experiment where we exposed different to radioactive antimetabolite. And what we found was the slope of uptake was very steep. But when you got to 3 minutes, it went pretty well flat. So one of the problems, the reason we stuck with 5, because we felt that if there was a bit of a variation in the upslope, your variation would be much greater than if you always use 3. So basically we use 3, although 3 feels like about 3 hours when you're operating.
So I do, if the child is an infant, I do 0.4 milligrams per mil for 2 minutes. If the child is over 12 and obviously 12 months, but obviously it's not hard and fast, it's 0.2 milligrams per mil for 4 minutes. That's what I do. So we have some other questions coming. What I'm going to do is I'm going to share the Menti results as we go, and hopefully we won't have any issues right now. So, Nicola, do you want to carry on the discussion? I'm just going to show where in the world we are here. You can see, guys, it is truly global. For an infant under the age of 3 months, which of the following would be your first choice of operation? And it's interesting that the majority of people are doing angle surgery. A minority will do some cyclodiode laser. The tube is at 5%. The combined trab at 17%. While I show these, I'm going to ask everyone a question. What is your trick to find Schlemm's canal if you're doing a trabeculotomy? What is your trick? Roberto, you start.
I try with the proline. With the proline, I warm the cut of the proline. I make it round, and then I try to feel it. And when I'm in, I try to close the eyes and feel it if it goes. Otherwise, I come back.
How do you even know where to put it? How do you know where to put the proline? How do you
if there is the blue-white junction, like I show you in the first picture, it's quite easy. Otherwise, you take time and look for it.
Sushmita?
Even sometimes there is no the Schlemm, I think, or it's not open.
Yeah.
A small tip that I tell the residents is it's the junction where the curvature changes really. So the sclera and the cornea, so there's a change in the curvature of both of them, and usually just at that if you get it. And once you start the scratch, it's very usual to see the horizontal fibers of the spur. And once you see that, it's right in front. So if you just dissect it out, and the other caveat is actually the thicker flaps are easier to then search for the Schlemms. Initially, you're so scared that your flaps are so thin, and then you keep digging in and you can't find them. So, you know, you should be a little brave and go deeper, and then it's easier to...
That's a good point. Peng? Peng, what's your tip?
I cut a square flap. Some people cut a triangular one. And I make sure that my incision goes as far forward as I can to where the reflection of the flap is, because sometimes the canal is a bit further forward than you think. I make a long incision, about at least half the length of my flap, right from the front down to the back. And then I slowly dissect deeper, and I use my knife to just reflect to and fro. And I think what you find then is in the majority of cases, as you get to the right depth, you'll see a tiny little trickle of fluid. And that's your absolute answer. Then you're there. Because then you can use a blunt probe just to see where that thing is. And if it passes easily, then you know you're going to use the 360 very easily. The biggest problem I think people find when I'm sort of trying to teach this is sometimes people don't go far forward enough. And just occasionally they get full in a very unusual case where they don't go back far enough. But most of the problems people find is they don't go far forward enough. And so if you just do this spreading technique, cut, spread, you'll find the canal in the majority of cases. Yeah.
So Alicia and Nicola?
I'm not doing trabeculotomy. Sorry.
Okay, no problem.
You go ahead.
Nicola?
I do an occasional trabeculotomy. tending to do more and more goniotomies, I would put them on Diamox for 10 days to 2 weeks to try and get to do a goniotomy, because it's now become more comfortable for me. But when I do have to do a trabeculotomy, I don't know if Peng was using his hand like this, showing he's cutting down, but I use a 15 degrees blade and actually cut upwards. So working that. So I like your idea of a longer incision, because actually the limbus is so abnormal in the ophthalmic eye that you don't really know where the junction is. So that long cut is important, but I use the blade the other way around, so cutting upwards slowly. That's all I have to add.
Okay, well, I'm going to give you my tips in a minute, but look at this one. What is your first choice for surgery for congenital glaucoma in a 3-year-old child? Angle surgery about 44%. Trabeculectomy 20%, combined 25%, drainage tube 10%, and cyclodiode lasers around 2%. How many people have done 360 trabeculotomy? 10%. So that's interesting. I think they're going to find your video very, very fascinating. Goniotomy is my preferred first operation for congenital glaucoma. That's 50%. So that's interesting. The tube most used in my surgical center is the Ahmed tube, followed by the Bearvelt, and nobody's using the Multino. I think that might change if you had an adult glaucoma audience, right? That may well change. So let me give you my tip. My tip, I have to thank John Salmon. When I was a senior registrar at Oxford, he taught me, he said, Ken, when white meets blue, Schlem waits for you. That was the first thing. And then the second thing that I do, and we publish this in the British Journal of Ophthalmology, is I get my anesthesiologist to occlude the jugular on the side that I'm operating on. And in an infant, when you do that, the back pressure causes Schlemms, if it's there, to fill with blood. So Peng, I do exactly what you do, but now I have blood that comes out of Schlemms, and I know exactly where it is. And my fellows find it easy to find Schlemms because of that little trick. So we have lots of other questions coming in. Avastin. Avastin was mentioned. Sorry, bevacizumab, when we don't have any conflicts of interest here. What dose and how does it work? What dose and how does it work?
Right. As you know, Avastin does have some side effects, and you have to explain you're going to use it. But in my experience, that's not an issue given in the eye. The dose that I use is the same dose that's provided in the preset syringes that are used for the AMD injections. One, because it's practically easy, and they're used to doing it. And if you try and make up your own concentration, forget about it. So it comes as a 2.5 milligrams, and we give 1.25 milligrams. But whatever the AMD people are using, which is usually that's fine. And that's the dose that I use essentially. Now, I actually give it intracameral, not intravitreal, intracameral. So it's very easy. You just put it through the paracentesis. The reason why I do intracameral is when we did our original antibody work with transforming growth factor beta antibody, we gave subconjunctival injections, and in fact the pharmacokinetics of that are much shorter. It only lasts there for a few hours. Whereas if you give it intracamerally, it'll last there for potentially up to several days. What is the mechanism of action? Well, it's a VEGF antagonist. And why would neutralizing VEGF make any difference at all to glaucoma surgery? Well, it's not neovascular growth, which is what the main action is. VEGF is the world's most potent vasodilator. And we all know that if we have an eye that looks red, it does very badly in surgery, and that's because you've got dilated blood vessels. And what happens to dilated blood vessels? They leak like mad. And they leak at all the terrible things. I mean, they're very good things if you want your wound to heal. They're terrible things if you want your wound to seal up. And so what the VEGF does is it mops up the VEGF, stops the vasodilation and leakage of the bad stuff into the wound, and therefore reduces the scarring.
So Peng, are you using it in all cases or only in uveitis patients and certain cases?
I'm pretty well using it in most cases now because I want all the help I can get with anti-scarring, because I know that if I can control the scarring, I've got that patient taped for the rest of their life. So, I'm doing everything I can to make sure that I stop their scarring. Really.
And even if you use a bar felt and you've tied off the bar felt?
I don't tie off my bar valve because I always make a blow valve anteriorly. So right from the beginning, there's Avastin flowing into the wound and neutralizing the VEGF. So
anterior to the plate in that case.
Yes, but because I have a long scleral patch that extends all the way to the plate, the Avastin flows all the way backwards and fills the plate. So and the reason I do that, of course, is that if my scleral patch is too short, then what happens is the eye just forms a ring of scar tissue around it. Whereas if I extend the scleral patch all the way, then the blow valve continuously drains for 6 weeks until the first stitch opens.
Okay.
So, Peng, I presume this is published. People listening to this could go and read a paper about this, about the Avastin in the intracamurally?
There are lots of papers published on use of Avastin in trabeculectomy. I haven't published the pediatric results yet, no.
Okay. But so so people are going to, because we're going to get questions, and I know people are going to ask about, so you use you use half the adult dose or the adult dose for AMD?
We pretty well use the adult dose, but if you give it, into the AC or subconjunctivally, it very quickly disperses, and it doesn't really get the same penetration into the, I know what you're worried about, the systemic circulation, but the systemic circulation levels of antibody given subconj or intercamurally are much less than intravitreal.
Thank you. This is fantastic. So we have, it's my phone is blowing up. Here it says,
yes.
Let's say, is it possible to cut Tenon's capsule? So you're doing a trabeculectomy. Is it possible to cut Tenon's capsule if mitomycin isn't available? So the question is how many of you, whether mitomycin is available or not, how many of you do a limited tenonectomy in an infant? Does anyone do that, Sushmita?
No.
Could do it if it continuously pops out and troubles me, but if it behaves itself, I let it be.
Okay.
But it's really exuberant and it comes right out, and that's when I cut it while suturing. Yes.
Nicola?
I don't cut it at all. I'd be cautious to do that because there's very thin conjunctiva left over that.
Peng?
I don't exactly the same as Sushmita and the others. I only cut it if it's actually getting in my vein. There are several trials in adults looking at tenonectomy and no tenonectomy, and it really doesn't seem to make that much difference. So I would be a bit worried about overcutting it and then having a problem with the conj.
And what about you, Roberto?
No, I never cut it. Never.
Alicia?
No, never. Never.
So I admit that I cut the anterior tenonectomy. I do an anterior tenonectomy, probably about 1 to 2 millimeters, because I find that when I close the conj, I've never had a leak ever since I did that, probably from 2001 or 2002 onwards. But I did have leaks because I think probably I didn't recognize when the tenon was exuberant. So I do take the 1 to 2 millimeters anteriorly away so that my conjunctival flap heals. So the other questions that we have, does anybody
While you're looking at the other questions, Ken, can I just ask a question? I want to go back to the last Menti question. We had Multino, Armet, or Barfeld. Yep. Okay. I'm sure a lot on the panel, I know Sushmita is probably not using the Barfeld, but using the RD by Orolab. Am I correct?
Yes.
Yes. And I think in a lot of countries, we are using the RD, which is a copy of the Barfeld and made in India. So my question to the panel, so that wasn't included, how many people are using the RD. There is some work coming out in some publications comparing it to the Barfeld, but I just wanted to know if you're finding the same results. Is the tube exactly the same as the Barfeld tube? If you're using a tube lengthening tube in tube, is it behaving in the same way as a Barfeld tube is? I wanted to know your opinion on that. Should we start with Sushmita?
We don't have the Barfeld marketed in India. but I've had occasion to listen to Dr. Jamie Brand because he's with the Orbis. So he uses the Barvelt in the US and he uses the RD on the plane because it's cheaper. So according to him, it's softer and it's easier to put under the muscles, but the tube is also less stiffer, so it's more difficult to insert. I mean, this is just off what he says, but I haven't had a personal use of it.
But that's exceptionally useful information, because one wonders if you've used the Barvelt in the past and you've now have to move to something like the RD, that you notice these differences.
There's one publication which compares the Barvelt to the RD, and the efficacy was quite similar. So they didn't find any difference in the IOP lowering, but they did say that you need to get a little used to the softer plate of the RD.
So I'm going to change. There are loads of questions. We'll try and answer them if we can. But Roberto, I've never done a 360-degree trabeculotomy. I always have worried, maybe the types of eyes that I get because of my cornea work, that I'm going to sort of rip something off as I pull that tube through. Have you ever detached Decimays when you've done that by accident? Has that been reported?
No. Because I use it only the microcatheter with the light. That's why I've never done with the Prolene, because with the Prolene there are few papers, but I'm really scared to use the Prolene to do 360 trabeculotomy because you really don't know where you are. And sometimes you are not really in the schlemm, or sometimes you have the anterior insertion of the iris. So when you pull, the iris damages could be very, very important. So if I'm not sure, or if I have not the microcatheter, I prefer to use conventional angle surgery.
So how many people on the panel have used 360 trabeculotomy, whether it's Prolene or whether it's catheter?
No.
Peng, do you use it regularly? I mean, you know, when in the indications?
Yeah, I do actually, and it's a good technique. I used it, I did it on different age children. I mean, I think your worries about the tearing it's pretty safe actually, and it doesn't. I've also done it ab interno, so because I don't like defiling the conjunctiva, which is so special to me. So I've done it ab interno as well, but it's a bit fiddly doing it that way, and it's better. And also, when I do it ab externo, I put 2 vicryl sutures in the flap, and I actually apply beta radiation, and sometimes I get a diffuse drainage bleb as well. So with that long cut I make, that's probably where some of the fluid is going. So you can get pretty good pressures with it. I think I'm very aware that it's very expensive, for many parts of the world, and it won't be available. I would share the thoughts I have about the Prolene, because the Prolene is it's much more difficult to do because you don't know where it is. And there's a very good picture of the Prolene curled up underneath the retina.
Publication by Dan Neely. That's the publication by Dan Neely.
Exactly.
Where it tracks right past the fovea.
Yeah,
exactly.
Yeah.
So you have to be jolly careful if you're using the Prolene. Some people are very good at it, but I'm a bit scared to do that.
Fair enough. So we're going to move on. 2 things. There was a discussion, a beautiful video of a very long track. I can tell you that I get cases of brittle cornea syndrome, congenital aphakia. That sclera is not thick enough for me to make a track through. I will definitely be in retina if I try to do that. So what I have found is that I found a couple of melts with sclera. Then when I went to irradiated cornea, that completely stopped. And what I love about irradiated cornea is I can see where the tube enters. My view of the tube is never lost. So if you can get irradiated cornea, this is cornea that's not good enough for transplant, get it irradiated. It's a really good tissue instead of sclera or doing a long tunnel. Because the case showed
again, sorry?
Irradiated cornea.
Yeah,
Why must...
I'm sorry?
What is that? I mean, what is it irradiated with?
Oh, so that's a good question. I just give it to my eye bank and they irradiate it for me. So I don't know. I can get the details. You know, it's X-rays. They irradiate it with radiation. Do you know, Peng? They use a radiation source that irradiates the cornea, so it kills all the cells, and all you're left with is with a stroma and the epithelium, and that's it. So it's sorry, not the epithelium, just the stroma. So it's commercially available in the USA, but it's expensive. But you can get it locally. I've used it in Africa and in China. So it can be got from your local eye bank if there is one there. So that's what I... Go ahead, sorry.
I use normal cornea, and it's not irradiated, although we could irradiate it. I think the radiations to kill off the epithelial cells or anything like that, if it's not being soaked in alcohol. But I think if it's soaked in alcohol, that's not a problem. So, and actually, I prefer cornea. If I can get cornea, I'll use it instead of sclera, because it is stronger, and you can see what's going on, as you say. So I use non-irradiated cornea, and I soaked in alcohol, and it does really well.
So we're running out of time now. We're 4 minutes over, but that doesn't matter because we're going to go till 10 minutes over the original time. 2 other questions. How many goniotomies would you do before you move on? So you do a goniotomy because you think it's going to work. Let's say it's a 1-year-old, and you get a year's worth, and everything's been great, and then suddenly you think, pressure's not so well controlled. And what would you do then? Would you do a second goniotomy in another site, Roberto? Or let's say you don't do goniotomies. You've done the trabeculotomy, and after a year the pressure goes up. What would your next stage be? What else would you do? Medically, you can't control it.
Yeah, okay. If I've tried with goniotomy, with trabeculotomy, and the pressure goes up, then I first check the angle. If I feel that I can open the angle again, I will try to goniotomy again. Otherwise, I enlarge the trabeculotomy, I do the first trabeculotomy, or I put a tube. But at least I try. If I can see the angle, and if I can see there is some choice to open again, then I will try, because it's easier goniotomy. So
you'll do it in a different site? So you'll do it...
Yeah, well, I try to enlarge, or to go again if I feel some synechiae, so to open the previous goniotomy, to open it again.
Alicia?
My first goniotomy used to be in the nasal side because it's more useful. And then if it's not enough, then I'll do a second goniotomy in the temporal side. And with these 2 goniotomies, I can control 80 or 85% of the cases. And sometimes I'll try to do a 3rd and a 4th, because with this 3rd and 4th, we have still 10–15% more of success. And what I do in the 3rd and 4th is to redip the 1st or the 2nd and widen it. I mean, do it wider than the first, than the previous. And I have good results with this.
Peng, Sushmita and Nicola, then we're going to have to start wrapping up.
I think it depends. Oh, sorry, Sushmita, carry on.
I would do 2, but just to add that I've also started doing a second goniotomy when the trap fails. When I did it first for cloudy cornea, so many times what happens is the cornea clears, but the pressure is not good enough. So rather than open the conjunctiva, you have the nasal angle, which is untouched. So I use a second goniotomy even in that case. But I would move on after the second.
Nicola and Peng?
Okay, Peng, go ahead.
It really depends on what the patient needs. You know, if they got a 0.9 cup and their needs are for, rapid, bit more corneal clearing and stuff like that, then I'll probably go for a procedure that's more definitive, because I know that my success rate with a drainage procedure of some sort is much, much higher than a second trabecular angle surgery. So just as Alicia said, your second go, your chance of getting the pressures down to really good sub-teens, to go teens, getting pressures in the teens is quite small. It's not 0. And so in particular patients, that's the right thing to do. But I think if they really need something sorting out, then I'll go for a definitive drainage procedure.
So what I do, yeah, I've noticed I'm taking photographs of the angles after the first goniotomy if we're coming back for the second goniotomy, and you can definitely see a difference between the two angles. But there are always peripheral anterior synechia in the operated angle. So I'm learning from this meeting that it would be okay to go back a third time if you see a lot of peripheral anterior synechia in your already operated, usually the first angle, nasal angle, then to do a third procedure, goniotomy, especially in those that you don't trust a tube or a trab for follow-up and so on. If you can get away with angle surgery, so to push on and do a third and fourth procedure if you see peripheral anterior synechia is definitely a good idea.
So listen, I have to bring, I don't even want to bring this to a close. I mean, everything is going wild here. I can't tell you how incredible this is. I want to share with you what people liked about this webinar. I think it's important for you guys to see this. Can you see that? Can you see the discussion? It says, this is an opinion cloud, and the opinion cloud shows that the discussion is what people have absolutely loved. Can we see that? Can you see that opinion cloud on the screen? The videos, the 360 trabeculotomy, the safe trabeculectomy, the speakers, even up there, even the speakers were liked. So that's a congratulations. I'm going to finish off by just sharing one other thing. Of course, I want to thank our amazing panel. You should be seeing a globe rotating. Are you seeing that, Nicola? Give me a nod if you are. Remember, this is an international organization. We have the listserv that David Granite runs. Please email him if you want to be a part. There's the Facebook page, which is really taking off. There's free membership. Doesn't cost you a penny to be a member of the WSPOS. Remember, we're together apart all over the world right now, and it's important also to remember that we have a big thank you to say to Entod, a massive thank you to say to Dara McCafferty, Akila Acharya, who are administrators for WSPOS. We're really sorry we had problems. We have listened to you. You wanted an amblyopia webinar and not a quiz. So next week, 1st of August, we're having a webinar on amblyopia. We react to your feedback, so give that to us. And I want to remind everybody, WW Connect, 26th of September. These are the fees. It's going to be an amazing day. Saturday, September 26th, 2020. Give us just one day, and we promise you, we'll give you the world. Thank you so much, everybody. Have a wonderful and blessed weekend. God bless all the panelists. I can't tell you, and my wonderful co-moderator. Thank you so much, everybody. Bye-bye, and God bless. Take care.
Thank you.
Bye.
Thank you.